all of you. It gives me immense pleasure to invite you all to the second lecture series on behalf of North Zone Indian Society of Nephrology. Without divulging tangentially, it is an honor to introduce Professor Anupam Agarwal, who is the Executive Vice Dean, Hirsing School of Medicine, and also Professor of Medicine, Biochemistry and Molecular Genetics, Division of Nephrology, Department of Medicine at University of Alabama at Birmingham. Dr. Agarwal is an extraordinary researcher, teacher, and the immediate past president of American Society of Nephrology. Last but not least, the most profound one is being the alumnus of PGI Chandigarh and student of Professor Chu. Now, the second chairperson is Professor Anupama Kaul. Professor Anupama Kaul is a professor at Department of Nephrology, SGPGI, Lucknow. She has researched extensively on community-acquired acute kidney injury in India, is an extraordinary clinician and a passionate doctor. With this, I hand over the rostrum to Professor Agarwal and Professor Kaul, please.
Thank you, Dr. Ramachandran. Really honored to be here and really honored to introduce my close friend and colleague, Professor Ravi Mehta. So, Dr. Kaul, would you like to introduce Dr. Mehta?
Sure, sir.
Yeah, please, go ahead.
Sir needs no introduction. Professor Ravi Mehta is an emeritus professor of medicine, director at UCSD Quest, and the Master of Advanced Studies in Clinical Research Program, University of California, San Diego. Sir is going to talk on a very relevant topic, that's kidney functions recovery and long-term outcomes of AKI, challenges and opportunities. Over to you, sir.
Thank you, Anupam. Thank you, Dr. Kaul, and thank you, Raja and the ISN North Zone for giving me this opportunity. It's an immense pleasure to be with you today. I am just going to just confirm that you can see my screen, right?
Yes, sir, we are able to.
Okay, perfect. So let me just hide the thumbnail video. All right, so before I start, I want to thank Raja for doing something which I will show you in just a minute. As part of this webinar, we also sent a poll to participants who were going to sign up, and I will be showing you some of the features of the poll as we go along, just to get an idea of what your thought processes are. These are my disclosures. They have no relevance to what I'm going to be showing you today. So here's the poll. There were about 56 responses till date, and most of these are nephrologists. There were some people who were intensivists and others in physicians in training. But one of the questions was, my hospital has guidelines in place for prevention diagnosis for AKI. It's interesting that if you look at the red, it is disagree. 12.5% strongly disagree. So about a third of people strongly disagree, but about half, almost 2/3 of the people say we do have these guidelines. So keep that in mind. A second question was, we missed some cases in my hospital. Again, we had about 33% strongly or disagreeing that they don't miss any cases. And about half of them say we do miss cases. And then when we ask the question, is current methods for diagnosis mean that it is often missed? We see again here is that there's a significant number of people who say they disagree with this. So they think and believe that every AKI is recognized. And the second question was, what proportion of AKI cases could have been prevented? And here we see that there is a range between about a third of people feel that about 20 to 30% could have been prevented, and a third of people feel 10 to 20%, and then we have the rest in different categories as such. And when we ask the question, there's sometimes a delay in diagnosing AKI in my hospital. Again, we see about 2/3 of the people agree, but we have some people who disagree in this category. And then the final couple of questions is, I believe that follow-up received by AKI patients after discharge is inadequate. And again, we have a significant number of people who agree here that the follow-up is inadequate. And then finally, there is a strong need for further medical education on AKI for all clinical wards. And you can see here is the vast majority of people agree with this. So with that as the background, what I'll be focusing on is an element which I think has become one of the most important areas for AKI. And I'll divide my talk into 3 sections: what is known, what we are learning, and what the challenges and opportunities are. So what is that we know? We know, first of all, that it is not a single disease. It is a syndrome, and you can categorize it depending upon whether you look at its setting, the reversibility, the injury mechanism. And when you look at this cartoon on the left lower end here, you can see that the multitude of settings and exposures which contribute to our diagnosis of AKI continue to expand. It just depends upon who is correlating them. We also know that we have different stages of AKI we've defined, but also we are recognizing is when the AKI occurs is also quite different depending on the course. We have extensive knowledge from preclinical models of the variety of things which can go wrong and the pathophysiology and mechanisms. And the big challenge therefore becomes is in any of these clinical syndrome classifications, which mechanisms and pathways are ongoing at any given point in time. But what I really want to focus on is that if you look at the course of patients following an episode of AKI, you can see here is that the vast majority of our information comes from people who are admitted to the hospital. And if we were to track them, you can see that there's a significant change on which people go down to what pathway. Some of them will need dialysis. Some of them will die during the process itself of the hospitalization. And among the survivors, there is a variation in terms of how much knowledge we have of what happens to them. But we are starting to recognize that there are downstream effects which happen to them. And these are correlated also in terms of what the outpatient management is and also what is the follow-up in these patients. We now have fairly good evidence that there are systemic consequences of AKI. You have encephalopathy, heart failure, gut changes, the bone marrow, the liver, and the lung. And what we really starting to recognize to a large extent is that the prior state of kidney health with respect to underlying CKD or the presence of other exposures ongoing correlates with these long-term outcomes in terms of whether or not they progress or they recover. And this relationship of AKI to CKD is becoming much more apparent, that we see acute kidney injury as a disease modifier for the development and further progression of chronic kidney disease and its downstream outcomes itself as such. So you can see here is a patient with CKD who has an episode of AKI is much more likely to progress downstream at a faster rate. And when we look at the long-term consequences of AKI, you can see here's the absolute risk. This is mortality. This is cardiovascular events, hospital readmission, and kidney outcomes. So at no point in the course here are we secure that AKI can be managed without us considering all these events happening. And just as evidence for this is a very nice review article which lays this out. So you can see when you look at the time points of follow-up, and this is just looking at the renal outcomes, there is excessive risk for 30% for CKD, CKD stage 4 or higher, further deterioration, and CKD development, multiple studies showing you the same thing. When we look at the aspects of a little bit more further, this is the development of proteinuria. And if you have proteinuria following an AKI episode which persists, you have a much worse outcome with respect to kidney dysfunction. You have more likelihood of hypertension and also an increased risk of diabetes within 6 years. So what's more important to recognize here is that the time frame is not limited to just the episode of AKI, but is significant long term. And that is also significant when we look at for cardiovascular events, heart failure is increased, myocardial infarction, stroke, and also atrial fibrillation. And you can see these durations are quite long. And these are large studies. They are not necessarily small single center. And this is the Assess AKI study, which was funded by the NIH, looking at patients, which was case control managed, that they followed patients who had AKI and case control with those who did not have AKI. And as you notice here, they followed them for 3 years. They looked at their eGFR and proteinuria 3 months, and then they annually. And when they look at the associations downstream, you can see incident CKD, progressive heart failure, all-cause death, all are increased except for these major atherosclerotic cardiovascular events. So when we think about this now, we realize that we are dealing with a disease process, which we need to consider what happens after the disease has already occurred. And we know there is all of these things I've already shown you here, but what that translates out in terms of an individual is a significant burden on disability, because these people can't go back to work as well as they could. There is a high cost related to this. And in addition, there is a significant loss of life associated with it. So that's what we know so far. So the question is, if we have that knowledge, what is it that we are learning overall? So the first thing that I think we are learning is that there are differences in outcomes from community and hospital-acquired AKI. And the way this has come about is that if we look at patients who come into the hospital with an elevation in creatinine within the first 24 or 48 hours, depending upon which criteria you use, you can see that these patients' course will likely be different with respect to whether or not they are discharged with recovery, they have new kidney impairment itself, they have discharged with progression of known CKD, they're discharged on RRT or referred to renal services. And what this translates out to is within the community acquired AKI setting, within each stage of AKI, there are differences overall of what happens to them. So what that suggests to us is we need to think about AKI and differentiating what has happened and brings the patient from the community versus where we are in some respects contributing to the AKI in the hospital setting. And what we are learning is, at least in most of the recent studies, that a large majority of patients have community-acquired AKI, particularly those in the low and low middle income countries rather than in the high income countries. The second thing we are learning is that the kidney function recovery is highly variable. So this is a study which is, I think, very, very interesting. It was published many years ago in 2013 by Dish Pannu's group in Canada. They had looked at almost 200,000 patients who had repeat creatinine measures available. And what they translated out is they characterized them, they met the criteria for AKI versus no AKI. And then they looked at how many people recovered here, about 70%, and 30% didn't recover. And what was important to see is that when they looked at the no AKI, which is these Kaplan-Meier curves, and this is the overall survival, this is the development of end-stage renal disease. In all of these categorizations with these Kaplan-Meiers, the people who had no AKI or those who AKI recovered, they had similar profiles. But in those patients where AKI did not recover, this was the worst prognosis in each of these categories itself. And in between the group that they did not know if they recovered or did not recover. But what's more characteristic here is essentially what is the definition of recovery? So when you look at this, if the serum creatinine increased from baseline, and you said at the point of discharge, the last follow-up, the recovery is to within 5 to 15% of this. And this is all based upon an increase. And here is the survival, and this is the end-stage renal disease. You can notice is that this is the hazard ratio with end-stage renal disease, So if the lower the rate of recovery, the higher the likelihood you have mortality and end-stage renal disease. So in a sense, if we were to measure how well the kidney has recovered at the last time point, it correlates with, so this is the magnitude of recovery correlating with the ultimate outcomes. But a second element which has come to bear is for us to understand is the pattern of recovery. So this is a large ICU data set from John Kellam's group in Pittsburgh. And when you look at this, here's about 45,000 patients, and they looked at early reversal versus no early reversal. So this is from day 0 to 7. And then amongst them, they categorized in terms of what happened in terms of the late versus sustained, relapse recovery, relapse no recovery after 8 days onwards. And what they see is, here's the group who recover within 48 to 72 hours. This is the late sustained. This is relapse recovery, relapse no recovery, never reverse. Notice that this is consistent, that as you look at this age-adjusted survival function, you have much more likelihood of mortality in those patients who do not recover itself. So this pattern overall, therefore, that becomes important for us to start looking at the time element of AKI and what happens. And this is a more recent study now from Azra Bihorak's group, where they looked at both an ICU cohort on the left side and a non-ICU cohort on the right side in a large hospital system. And they classified these patients as persistent AKI with no renal recovery, persistent AKI with renal recovery. So these are the group of people who had more than 72 hours, but they ultimately recovered. This is rapidly recovered, and this is no AKI. And then they also looked at an early versus late AKI, early being that the AKI was in the first 48 hours. So to a large extent, reflecting community acquired versus hospital acquired in the late AKI. And again, notice here is when we look at these categorizations of no, rapidly reversed, persistent with recovery, without recovery, you can see that the worst is the persistent AKI without renal recovery in this red. And the next one is those patients with persistent AKI with renal recovery, and ends at 4. And this is the same thing. This is the probability in the non-ICU cohort. This is the ICU cohort. The Kaplan-Meier curves are a little distinct, more likely of early changes in the ICU, but not in the non-ICU cohort. But what's more important here is that when we look at the other elements in a systematic way, so here, when we look at no AKI versus AKI, AKI has a worse prognosis. When you look at no AKI, mild AKI or severe AKI, you see a further stratification. When you look at the mild rapidly reverse, severe rapidly reverse, mild persistent, severe persistent, again, differentiation. And then finally, when you put this with respect to the recovery status, again, further stratification. So what this is starting to tell us is that we are unable to, and we should not be lumping all AKI patients in the same category. We might use these stratifications as consistent with different phenotypes, because these phenotypes have different courses. And therefore, it allows us to start thinking, how do we handle these patients with different phenotypes? The third element we are understanding is the time to kidney function recovery is associated with outcomes. So this was a study published in JAMA, and looking at the patients from the Assess AKI study. And here they characterize those patients as having resolving or non-resolving based upon the fact that if the creatinine concentration came down to within 0.3 in the first 72 hours, it was resolving versus non-resolving. And again, as you see these Kaplan-Meier curves here is no AKI, this is survival probability, the risk of major adverse kidney events, including dialysis or mortality. This is the risk of CKD incidence, and this is the risk of CKD progression. And again, you see this distinct separation based upon resolving no AKI, non-resolving AKI. And when we look at this in terms of the hazard ratios here, you can see that there is a significant increase on the unadjusted, but even in the adjusted hazard ratios, that they are all significant. So this suggests to us, we need to start paying attention to not only the time, but also the pattern itself. And This is further stressed by another study. This is from patients from the Veterans Hospital. And you can see here is, again, if you have serum creatinine less than 120% of baseline, and you look at the days it takes to recover, 1 to 4 days, 5 to 10, 11 to 30, 31 to 90 days. And you can see here's the hazard ratios with respect to a sustained decline in EGFR end-stage kidney disease over 42 months follow-up. You can see that in each of these, as you go, the longer you go, the higher the risk for progression and worsening renal function. And this is also evidenced by this another study is looking at in elderly patients. It's looking at 90-day mortality and chronic kidney disease progression. Again, in this category here is 1 to 2 days to greater than 7 days overall. Here's the staging. Again, you can see similar patterns. This is stage 1, stage 2, stage 3, with duration 5 to 7 days. So this is the interaction. If you have a stage 1 and it lasts 5 to 7 days, you're probably okay. But once you start getting down to stage 2 and stage 3, the longer it lasts, the more likely you are to have a more likelihood effect on all the other outcomes as you go along. The next thing we are recognizing, and I think is probably the most important for us to consider, is that acute kidney disease is being recognized as a major contributor. And what we now start thinking about here is, here's a starting point. The baseline state of kidney health is what we often don't know. But it starts becoming an important element that if we were to characterize these patients with a variety of different biomarkers, we may be able to pick up subclinical AKI. And then if you go into the creatinine clinical domain, where it's a current classification here, you can then see some patients will recover to full, some have apparent full recovery, some will have CKD, and also this translates into what is happening in terms of repair processes. So based upon this, I asked one question in the poll, and this was, which of the following best reflects the concept that is designated as the presence of structural or functional kidney damage greater than 7 and less than 90 days? And I want you to all reflect on this a little bit, because the answers from these responses said 2/3 of the people believe that AKD occurs following AKI. A fragment, about 15%, believe that AKI is a part of AKD, and a fewer believe that AKD can occur in patients with CKD, and then some people are not sure. So I'm going to try and clarify for you, because this is an important concept we are emerging. So when we came up with the definitions of AKI, we said a 7-day window defined AKD. And as we all know, CKD requires a presence of structural or functional change for more than 90 days before you get the label. So that leaves a gap here. So even in the first KDIGO elements, we recognize that we will have patterns of AKI. This is the normal staging, but it depends upon where you're seeing the person and what is happening to them overall. So as a consequence, we had a AKI meeting on this in 2016, and we said we need to be able to get to the better of defining what this AKD is, and suggested that there was a minimum of 48 hours to separate the two distinct episodes, but also to recognize what's persistent or non-persistent. And this was sort of the thought process, is that you could start with AKI and you'd go on to AKD, and then you'd go on to CKD. So the thought process at that point was, well, AKD always follows AKI as such. But what we're recognizing actually is that AKI is embedded within AKD. And there is this interaction here of when AKD transitions into CKD. And why is that important for us to recognize? So there's been a KDIGO harmonization conference on this. When we look at it, here's the functional criteria for AKI, which are currently in place. And there are no real structural criteria, although we have proposed new definitions to incorporate biomarkers as a subclinical element. But AKD is less than 3 months, and these were sort of the diagnostic criteria for AKD and the presence of markers, and then CKD here and NKD. So notice now that you've got these 4 categories, but these 3 categories are things you can characterize patients at baseline. And I'll show you how that would occur. So at baseline, if you don't have any knowledge of anybody that they're felt to be healthy, they could either be NKD or they could have underlying CKD. And the question is, if we have some abnormalities here, but you don't know how long they've lasted, then they are actually a categorization of AKD. And then when you monitor these patients and follow them, and if they build and meet the diagnosis of AKI, then they have got AKI superimposed as part of AKD itself. So here's sort of the thought process as it's emerging now, is that AKD is the larger group amongst which you can meet the criteria of AKI, and then the characterization of this can be from either of these elements, and this is the GFR and albuminuria staging of AKD, and this is the GFR and albuminuria staging of CKD. This is robust. We don't know how well this performs at the moment. And what is the evidence for this? So there is a variety of evidence which is emerging now with respect to saying is, so here, most of these cases are AKD phenotype after AKI. And what's being so associated, that this phenotype is associated with a higher mortality. It's also associated with higher incidence CKD as we go along. And this is reflective regardless of these studies. Now, we approach this in the same manner in the 0/25 study, which we published a little earlier in a couple of years ago. And when we see in this setting, we had this in Nepal, Malawi, and Bolivia in remote centers. We included almost 2,000 patients here. And in these centers, we went out to the community centers where there were no physicians. We assessed patients based upon a clinical risk score and did a urine dipstick and a serum creatinine with a point of care instrument on a single finger prick stick. And when we characterized these functions at renal functional enrollment, they were put into 3 categories. That there was prior knowledge of chronic kidney disease, there was normal kidney functions who did not fulfill criteria for CKD, and then those patients who met any of these criteria, we classified as AKD. And what you see here is that almost 65% of the patients met this AKD criteria, about 25% did not and were normal, and only about 9% CKD. But what happens to them is instructive. So when we looked at what happened to their renal functional status at 7 days, again measured by the serum creatinine values itself, and either by a decline in serum creatinine or an increase in serum creatinine, we recognize that these categories now have AKI incidences come into play. And what we see here is that here's the at enrollment, here's the 65% people who are AKD, about 33% of them developed AKI, amongst which about 46% of these were from a decline. Of the people with CKD, about 46% developed AKI, and amongst those who were normal, only about 13%. So again, you can see that this stratification starts looking at what you come in with at baseline or where your prior state of health is, and then you classify what happens with AKI. And this has been proven to a larger extent with a much larger study from Canada, where they looked at the entire population in a province. And you can see they have almost 1 million patients here as a spot, and they characterize them by their knowledge of CKD based on GFR less than 60 or albuminuria. They utilize the same classification for AKI as we do here with the increase or decrease. And then they classified those with AKD without AKI based upon these categorization. You can see here is that they looked at the residents in 2008 versus in the census, and you see there's a significant number of people who have AKD as such. But what's more interesting here is that when they looked at these different outcomes of mortality, the CKD development, CKD progression, or end-stage kidney disease, there's a strong relationship or the presence of AKD, and that's better illustrated in this graphic part here. So here we are looking at mortality, CKD development, CKD progression, and end-stage kidney disease. And in all these categories, you notice that is the group which is associated with CKD and or AKD has the worst prognosis. So we are starting to see that this AKD, CKD element is a much more important way for us to characterize. And sorry, the connection is from. Could we have somebody? Okay. The next one is that outcomes are similar regardless of the setting in which AKI develops. So when we looked at patients with sepsis, it's a retrospective study. Again, staging, here's the reference, is the hazard ratios go up. So it doesn't matter whether you have sepsis patients, it's the same with patients with hematological malignancy. You have the same elements downstream as such. We also know the same thing is happening with COVID-19. So this is a group where they had a retrospective study and looked at looking at patients with COVID-19 versus influenza. And you can see that the overall rate of acute kidney injury was higher, the overall mortality was higher, and those with AKI, however, and here's the recovery rate at discharge. So it doesn't seem to matter what the setting is, we are seeing the same framework emerging overall. And this is the same question here in terms of patients with veterans with COVID-19. And here 47% are unresolved at discharge itself. And even though the phase of disease changed overall, but there was a significant increase in death and or longer hospital stay. So with these elements here, the question comes up is how well are we doing as a community? And this is an interesting study, which is from Yale, where they looked at the Yale hospitals, another hospital, one in Chicago, at Jay Coyner's Hospital, and they looked at the KDIGO guideline recommendations of what needs to be done overall. Notice here, this is a fairly large study. We've got almost 9,000 patients here. And what you see is that the outcomes with mortality are different overall in these patients. But the 30-day readmission rate is striking. You have almost between 18 to 25% readmission rate. But when you ask the question is how well, these are all electronic medical records, so they could be reviewed. We ask the question is, how many patients were continued on kidney-related medications after severe AKI? You see almost 40%. Aminoglycosides, continued exposure to non-steroidals, continuous to ACE-ARBs. This is medication use after all. And you again see there's still new medication use. And then creatinine checked 24 hours, 48 hours, or 72 hours here. So very few patients in the first 24 hours are rechecked as such. And all the other best practice measures with respect to what is being done. And I want you to notice this one here is urinalysis. Very few, less than 50% of the time is urinalysis being done in these patients. So what that tells us is that we have a long ways to think about of how we might modify these cases as we go along. The last part we're seeing is AKI patients requiring dialysis are at higher risk. This is a group, this study for looking at patients with cirrhosis. You can see they've got these primary outcome is kidney recovery off dialysis for more than 30 days. And again, the sub-distribution of kidney recovery here is obviously dependent upon the underlying stage and whether or not they get a transplant as such. The same aspect is for those over the last few years, we have now been tracking what happens to acute kidney injury requiring dialysis in the USRDS system. And amongst these million incident dialysis patients, there were about 32,000 which were incident dialysis due to AKI. And we notice here is that these patients, in compared to those with diabetes, they have a higher hazard ratio for mortality, both at 0 to 3 months and at 3 to 6 months. And the recovery of kidney function is less, and it's much more less in women and Blacks and Asian Americans. But what's more important is, if those patients were to compare outpatient dialysis who got it from AKI to incident long-term dialysis patients here, you see here is that the non-AKI incident dialysis patients have this adjusted mortality. But notice these patients on AKI on dialysis, 16% die, 19% recover, but 66% continue. And this is the hazard ratios for mortality at 1 year outcomes, depending upon where they are. So this is a very vulnerable group that we need to pay more attention to. So my last part now is just to ask about what are the challenges and opportunities that we need to think about. So the first one is, how should we assess AKD? So here's the question is, what should be the definition for recovery? And here it comes down to saying is, what is complete versus partial? What is complete versus partial? So these are different definitions. So this is the ATN definition, this is AKI, this is Nishpannu, this is KDIGO. And you can see that based upon what criteria are being used, you would have different percentages of patients who would qualify as having recovered or not recovered. And so this is an important area we still need to address. And at the moment, most of the epidemiological studies are reflecting a percent change from a reference point. And I qualify this is, in my mind, when we talk about a baseline creatinine, it should reflect the prior state of kidney health, whereas the reference point is from where we track whether or not the person has AKI and or has recovered to that point in time. You can have a secondary recovery relationship to what the baseline state of kidney health is, but in many patients, we don't know what their prior state of kidney health was. Therefore, we must have a reference point. And the reason that this becomes important is, if you were to track a renal functional change post-AKI, and you had this group of patients, this is a patient in red, and this is a patient in blue. The blue patient, and they both start off with the first value here. The patient who is in blue, if he is sicker and gets more frequent measurements, you would be able to track the slope differently. But in this red patient, the red patient is tracked more frequently, the blue patient isn't. But we don't necessarily know what happened during this period here and how they are progressing, because there's both bias and confounding at every level. So what we really are tracking now is essentially saying is, when you see a patient come in, first ascertain their baseline state of kidney health, and if they have AKD, if they develop an AKI episode, we stage it during the AKI event. And then as they go past the 90-day cutoff, we base the AKD and CKD staging on GFR and albuminuria. This is an area which is still open to a lot more research to be done over the next few years. The second question is, how should we identify patients at high risk for non-recovery? And here, when we look at the pathophysiology of recovery, you can see that you have an episode of acute kidney injury. It triggers a variety of mechanisms and pathways which come into play. And as we go down this pathway, depending upon how intense these are, what else is happening here, you end up with either chronic kidney disease or a pattern of recovery. So I asked the question in the poll, which factors have not been associated with non-recovery of AKI? So a double thing, not been associated with non-recovery. And you can see that about a third of people feel oliguric AKI has not been associated with non-recovery. Duration has not been associated. Severity has not been associated. So I wonder if the interpretation of this question was somewhat difficult, because the question or not, because all of these have to a large extent been associated. So we know, for example, that from epidemiological study, these are the patient-related factors. This is the severity of disease and the severity of AKI, all have been associated with non-recovery of renal function. And a question that comes up is, are there any specific biomarkers which can predict the recovery from AKI? And again, in the poll questions, the vast majority of people said all of the above, but some of them said here. But I think the largest evidence we have to date, and I'll just show you that in a moment, but here's sort of a nice review which suggests this. They have been associated, but none of them have been characteristically predictive of who needs RRT or has got other elements. So we don't at the moment have a single biomarker amongst this group which is predictive. The one which is most likely to emerge is CCL14. So this was a study, with the Ruby study, and where they looked at a large multi-center international cohort, but only had 331 patients here. And they characterized those patients with persistent severe AKI, this is stage 2, stage 3, more than 72 hours. And when they looked at these different biomarkers, they found that the area under the curve was best for urine CCL14. This was further validated in the same group. They had another study, which is the Sapphire study, and they looked at the same element. And here you can see the area under the curve for the Ruby and the Sapphire is in the 0.82 range, similar as such. But what's more important, when they do a simulation, so this is a simulation, and they looked at the CCL14 concentrations. So this is with a prevalence of 12%, 20, 30, 40, 50%, you can see that the risk would go up as the levels go up. Now, the evidence for this is from another study, which is in cardiac surgery patients. So this is from Alex Zarbach's group, and they assessed about 1,000 patients for eligibility, ultimately took 100 patients here, were characterized as persistent severe versus non-persistent severe AKI. And what you see here is, this is the CCL14 levels, which on those people who don't have persistent AKI, and these are the CCL14 levels which have high. They both start high, but this one comes down and this one stays up. So whether or not these positive and negative predictive values will play out in larger data sets still to be seen. But they postulate that the mechanism here is that CCL14 is a reflection of the underlying inflammation which is going on and the development of specific cellular phenotypes which differentiate into pro-inflammatory cells as such. So the bigger question to my mind is, how should we manage these patients to improve outcomes? So when you think about it, the first aspect is we need to have an accurate and timely prognosis. We need to limit the complications, and then we need to have measures to specifically enhance recovery. But the problem is the early recognition depends upon, at least for nephrologists, as to when we are consulted to see these patients in the hospital. It's unlikely that we are the primary person seeing them. So that means that whenever we are in the process, we need to make sure that we have an early enough consultation to make that happen. And then this is the construct of AKD and then the AKD sequelae that we talked about earlier. But I think what is most instructive is to recognize that whenever we are seeing these patients or we are coming into play, we need to think about what is the relationship of what we are doing in process of care, which is influencing these outcomes. So this is a very nice study looking at the adverse drug events during AKI and its recovery. And they looked at these patients here on electronic health records, about 1,400 patients, and looked at about 900 patients with AKI, and then screened their charts to see how many of them were being exposed to specific medications as they went along. And this is an illustration of how they looked at individual patients. So here's a patient who has a creatinine here. This patient's creatinine starts increasing, and this is the criteria they used, 0.5 milligrams in 48 hours, a little different from the KDIGO definition. But then they said, okay, if this patient met this criteria, let's look at what drugs they were being exposed to during this period of time, and then what happened here. So notice here's the vancomycin doses, and as this patient's creatinine goes up, they adjust the vancomycin. But this patient continues on the ACE-ARB here, this continues on the non-steroidal here till this point while this is going up. And then once this patient is recovering, the vancomycin dose is not adjusted downwards. It's to adjust for the recovery aspect of things. And so this is sort of their incidence. And what they notice here is amongst these are the potential adverse events, and these are the adverse drug events. And you can see that they are a significant variation of what can be happening there. But most of the drugs which are involved in terms of the event rates are the ACE-ARBs, the antibiotics, and then the non-steroidal anti-inflammatory drugs. So it's unclear whether this is a prescription from a different segment in the population, for example, orthopedic surgeons or surgery or elsewhere. But the point is, this is an area that we are tracking overall. So in terms of if you were to individualize care, potential interventions here would be obviously teaching and education. This is a huge area which we need to work on. The second one is in terms of medications for non-steroidal use and blood pressure levels to be tailored. We don't have clear evidence to be able to say that these work. So I asked these two questions in the poll. First was, well, in my practice, when I see a patient with AKI who has been receiving ACE-ARB previously, I do the following during the episode of AKI. So 2/3 of the respondents said they would hold it, and about 1/3 said we would stop it altogether. And then the rest, there were some people here who said they would continue it. The second related question was, in my practice, when I see a patient who's recovering from AKI, who was previously on ACE-ARB that was stopped in the hospital, I do the following. And here, again, more than 2/3 said wait until the kidney function return to baseline to restart. And about 1/3 said they would restart right away. So we have this variation even in our own groups of what our minds are and what we do. So what is the evidence for this? So when we look at these large studies here, and you can notice that they range from 500 patients to almost 46,000 patients, all of them suggest that when you hold the RAS inhibitor, when you use the RAS initiation after renal recovery, you find that you have a lower risk of mortality. So it seems to be protective in that aspect here. When we look at these new and continued RAS inhibitors used within 6 months after AKI, against reduced mortality itself. And so there is this suggestion that you should hold it while they are in the episode, but then consider restarting it. And so in the COVID aspect, this has become a bigger question, knowing that COVID associates to the ACE-ARB receptors. And you can see this is from the ERA-EDTA COVID-19 database. They looked at it and said, ACE-ARB discontinuation does not associate with anything to mortality, because these hazard ratios are not significant. Even though they look that they are associated, they are not significant itself. And then more importantly, this is one of the studies which is just recently published, again, from the same data I had shown you for patients who were having COVID-19 compared with influenza. And they say here's non-users. This is RAS inhibitors with users and who had influenza. This is COVID and RAS with COVID. In both cases, patients who had been exposed to RAS inhibitors 14 days before or had the medication listed as being given, they had a higher rate of AKI within each of these groups. Proportionally is not different, but in essence, overall, the COVID cases were higher rates of AKI in general itself. So there was a higher odds of having AKI when you had COVID, but really no difference itself with respect to between the proportions between the two related to ACE and ARB utilization itself. So what should we do? We had an AKI meeting and we had suggested this aspect. We had said, if you look at a population, we might want to think about two things. We had this acronym of MISS, consider the medications, the imaging, surgery, and sick day for exposures in this, and this is the education which goes to in. Then you have kidney health assessments, and we characterize this as ABCD. This is AKI history, blood pressure, CKD, serum creatinine, and drug list, and a dipstick as such. And then as we go down this is the kidney health responses, medication adjustment, minimize exposure, message the care team, and monitor. And so this is a proposed approach of how you could do it. And several centers have been using this with respect to AKI care bundles. So this is a nice meta-analysis showing you here's the hospitalized patients is a systematic review. You can see before is the blue, the red is after, and you can see to a large extent, most of the studies show that after an intervention with the bundle, you have better adherence to different elements. However, the risk ratios here don't necessarily suggest that whether it's occurrence of AKI or occurrence of kidney replacement therapy are quite different with the bundle. There is some suggestion that some of these areas may be something we can utilize for reducing in-hospital mortality with and without an AKI care bundle as such. So finally, on this element, I think I bring you back to this construct that we must start thinking about AKD, AKI, and CKD staging itself. And right now, we don't have specific guidelines of what to do with AKD with or without AKI. This is an area for research which is continuing as such. My last point here is who should provide the care? So when I asked this question in the poll, and I said, well, what do you do? It's interesting that over almost 90% of the people here said we checked the serum creatinine and urinalysis within 1 to 2 weeks and called the patient with specific instructions for follow-up. And the other half said we check serum creatinine, urinalysis, and check and follow up in nephrology. And the very few said they do not have a protocol. I'm not sure how reflective that is of practice, because to a large extent, when we look at AKI care in the continuum, we are seeing only a small segment of them as nephrologists, but in the community, it's a much larger element as it goes along, and a lot of patients get missed at follow-up. So here's AKI in the hospital. You can go down these pathways that I have enunciated already earlier, or what happens. This clinic follow-up from what happens to a large extent depends upon who's involved. Is it the primary care physician? Is it people who are going to help the person rehabilitate? Is the person with outpatient dialysis and staff? All are going to be needed to be engaged in this patient's welfare. And to a large extent, if you look at these patients who are coming up with stage 2, stage 3, some of them will need to be seen by nephrology on an ongoing basis, and others will need to be managed by their primary care or other physician colleagues who need to be aware of what to do in this setting. So in order to come to that, we came up with another AKI meeting where we had suggested that not everybody is going to be tackled by nephrology-based providers. So we had come up with this acronym again, saying is if you have a short stay, stage 1, non-nephrology care providers are the primary people, but as you go down the severity and you go into this red zone, it's much more likely you need nephrology-based care provision to be done. And does that work? Well, there is a very small study here suggesting that when you look at these eligible patients here, there is some improvement in a rehabilitation structured program to look at 30-day and 90-day mortality or rehospitalization is reduced. There is now a large NIH study, which is just starting as COPE-AKI with 4 centers, and Anupam Center and is one of them included in that, so we'll see. And then my last question was, what is your approach for AKI patients who require dialysis at hospital discharge? And you notice here about 2/3 of the people said we adjust the dialysis frequency and duration based on monitoring of urinary clearances and clinical characteristics. I would venture to say not many people actually do urinary clearances. They don't do urinary clearances during the hospital stay itself and also outside, but I may be wrong on this. But you can see about 20% don't have any specific protocol as such. And why is this important? I think that these patients require individualized care much more than anybody else. And here we have this acronym in terms, this again from the AKI Quality Initiative, weight assessment, access for dialysis, teaching, clearance, hypertension, medications are all elements. And these patients, as I showed you earlier, are the most vulnerable itself. So to summarize what I've shown you is, I think that amongst all the areas of AKI, this is the one we need to focus on the most now. It's associated with significant long-term adverse outcomes. We have all these elements here which contribute to those outcomes. And we need to develop these practical standardized approaches for follow-up and management to improve outcomes. I'd like to share with you a resource, which is the crtonline.com, where we have a lot of these videos and different tools available for you, and it's free of charge, so please access it. And then finally, to invite you, hopefully, to come to San Diego or participate in this at the next meeting, which will be March 29th to April 2nd. Thank you very much.
Thank you, Dr. Mehta. That was a brilliant presentation. Really appreciate the scope of your talk and going into details that we normally don't pay a lot of attention to. Before we get questions from the audience, I've seen some questions posted in the chat. Can you talked about RAS in flu and COVID, from Eddie Sue's work. I wonder whether, from your work on the global AKI in COVID, can you comment on the recovery in COVID patients with AKI and long COVID? Are there parallels to non-COVID AKI, Ravi?
So what Anupam is referring to is, so as part of Anupam Center, UAB and UCSD have an NIH-funded O'Brien Center for AKI Research that we are in our third 5-year cycle. And when COVID started, we initiated a multi-center international study of tracking patients with kidney disease and who are hospitalized for COVID. So we have now about 4,500 patients recruited into that cohort, some of them from a lot of centers in India too. And we have started the longer-term follow-up on them, but right now the analysis we have done suggests that these patients again have a differentiation whether or not they come in with AKD, CKD, and or AKI de novo. To your specific questions, Anupam, we have not as yet been able to look at the longer term outcomes with respect to RAS and ACE inhibitor exposure. We are in the process of looking into that.
Great, thank you. We'll get one question from the chat box from Dr. Ramachandran. In limited resource setting, what do you recommend on following AKI cases?
I think at the very minimum, I recognize, having lived and trained here and then come back periodically, is that we do not have electronic health records here. We do not even have medical records as such. Patients carry their medical records with them and bring them to the evaluation itself. So at the very least, one way to do that is to highlight, even with a highlighted marker, on that little medical record card that they bring, that they have AKI and needs to be followed. And if you just highlight it with a yellow highlighted marker or whatever, that starts putting an alert, at least to whoever is going to see them, that they need to be monitored for their kidney function. And at the very least, you can do a urine dipstick. You can do simple things which don't require a lot of resources. And then the other thing is, with COVID, all of us, including everybody here, has used telehealth as a real way to get in touch. I think that's another great opportunity for us, with a simple connectivity with the patient wherever they are, just to ask them how they are feeling, what is happening, which we don't do to a large extent. I think those two simple measures could be implemented no matter where you are. And I hope that would be something that could be done.
And one other question, is there any difference between the various causes like sepsis, pregnancy, cardiac surgery related AKI with respect to end-stage kidney disease progression and mortality?
No, as I've shown you there, obviously the underlying severity stage, the duration, the persistence, the underlying comorbidities all influence it. But what is coming through, at least to my knowledge, is it doesn't matter how you got to AKI. What matters is what you do with it after you have it. That's where we need to be paying the attention. That is the process of care that is under our purview, at least doesn't hurt the person anymore. And I think we don't do. I could speak from my own experience in our own centers, we don't do well.
Thank you. Dr. Kaul, do you have any questions? Please feel free to post questions in the chat box as well.
There is one question to address to you, sir. Actually, when we're talking about AKI and those patients who have actually recovered, So how do you follow, how long to follow them up in terms of whether we follow through the clinical biomarkers or anything else which can like suggest us that these patients should be followed for a period of time? Because there is a lot of literature saying that females who had a normal renal functions after an episode of AKI had incidences of maternal and fetal complications subsequently with pregnancy. So how long should they be followed and how should they be followed?
So let me answer that in two first things. First of all, if you have a patient who has been in an intensive care unit, I would caution you that the serum creatinine level after an admission to the ICU is poorly reflective of kidney function. Because they lose muscle mass, they also have reduction overall. And so you might see that the creatinine level has come down to below what they came in with, but that doesn't necessarily mean. So in those settings, it is really important to do a clearance assessment or at least look for urinalysis and proteinuria. Having said that, if you do have a patient who has apparently recovered, I think it's more important to see what other factors are going on as continuation. Are they on the right medications? Are they on other things? In several instances, if it's a transient AKI, they got well, they are young, they don't have comorbidities, I think they need to be followed just by their primary care people. But it comes down to educating the primary care team that this patient had an episode of AKI. In those patients who are deemed at high risk, I would suggest that they at least be followed for about 12 months just to see where they are.
Thank you, sir. There's just one more question, sir. There is limited therapeutic options available in patients to prevent progression of AKI to CKD. So where do the DPP4 inhibitors stand there in prevention and restriction of progression of AKI to CKD?
I don't think that there is anything specific that we have at the moment on this. I think there will be obviously intense interest in terms of the SGLT2 inhibitors and all the newer drugs and the MRAs, whether or not those would categorize as a way to reduce fibrosis and or to improve the likelihood of recovery. At the moment, there is no drug that we have that is specific for improving it. But as you can imagine, it is a wide open space. The trouble is that very few drug companies are investing in the AKI space in that part of it because of the heterogeneity. Because of all the stuff I showed you, if there are so many different phenotypes, the likelihood of a clinical trial being successful is dependent upon reducing that heterogeneity. And that's the big challenge for us.
So please unmute yourselves and ask a question. I know this group is not shy. Just think of this as lecture theater 1 at PGI. So.
Hello, Dr. Ravi. It was a wonderful talk. P.L. Gupta here. Hello, able to listen?
Yes, Dr. Gupta, we can hear you. Yes.
Yeah, it's a wonderful session. I mean, not a common thing for most of us. You have heard widely the timeline of AKI and cleared some confusion about AKD. I just want to ask, what is the role? Anupam already asked you the role of biomarkers in following up the AKI and what can predict the development of CKD in our setting.
I think it's a very difficult clinical element at the moment because the availability of biomarkers is limited. And also our experience in larger settings outside of the research setting are not there. I think there's value to it, but it will depend upon how frequently, how easily we have the biomarker coverage. And also to a large extent, at least in the US for fee-for-service institutions, who pays for it? That's the bigger challenge because it's just getting a sequential check on biomarkers or even one check of biomarkers is currently prohibitively expensive and we don't have any mechanism to really pay for it. So that's the limitation.
One more question, although it's not part of your talk, what is the current status of 0/25 of which you have in the one of the investigators, main investigator?
The ISN has implemented a follow-up implementation phase in this, both in Malawi, Bolivia, Nepal, and also expanded it to Brazil and South Africa. I am not involved in that phase at the moment, so I don't know much. I think Dr. Jha would probably have a much better feel for what the findings have been so far.
Thank you.
Vivek, do you want to comment on that follow-up question about 0 by 25 and where they are at?
I think Vivek may have left. Ravi, Vijay here.
Hi,
Hi, Anupam. Very good talk. Just a practical question that about the ACE and ARBs restarting after recovery. What stage of recovery would you wait? Say a practical kind of a question for clinicians here in India. Many patients are on ACE and ARBs. Usually during the episode of an acute kidney injury, ACE and ARBs are stopped. And what phase of recovery at what time? Would you start early? Would you wait for 6 months and then start? What would be your guideline, a practical kind of a guideline? The research evidences that you have shown are also still confusing. They're not very clear.
I think that's an excellent question, Vijay. And I think from what I can glean from the literature to a large extent, it depends upon what was the primary indication of the ACE-ARB. So if somebody was on an ACE-ARB to manage their cardiovascular events and or other specific reason, and they got AKI and they are recovering, then your primary determination of when to start may be driven by what the primary reason was, and it still is required. If you're considering ACE-ARB de novo in somebody who was not previously on ACE-ARB, that is a more trickier question at the moment. And there, the chances are would be you'd probably want to wait till you've got reasonable features. You don't have, ongoing exposures which would limit kidney function as such. I don't know that there is clarity on that at the moment. I don't know that anyone has come up and said, is you wait till it's stage 1 or it's equivalent down to full recovery or it's ongoing. There is obviously some evidence that if you have ACE-ARB, you have a reduction in downstream mortality and also progression. So the timing is still a little bit unclear. And I think we just have to probably weigh and balance and individualize it for each patient.
Would albuminuria or degree of albuminuria make a difference, I think?
Well, I think it would, but I think it also depends upon if you have a diabetic or not. And if you have a diabetic now, whether you're using SGLT2 or not. I mean, it's all these things start coming to play. If you have albuminuria de novo of post-AKI, I think that's a risk factor for downstream events. So how you control that would be an important element.
Dr. Jha just responded that the ISN is reimagining 0 by 25 to convert it into a global advocacy initiative that will be chaired by Dr. Jorge Cerda, who also chairs, as you know, the ASN AKI Now initiative. Other questions, I think we are definitely love to hear from other questions. Dr. Mehta would be glad to answer.
Can I ask, this is Narayan Prasad from Lucknow, sir. Hi,
Yes, Dr.
Professor
Prasad.
Mehta. Hi, Professor Agarwal. Sir, wanted to know about, we have published about COVID AKI experience of about 3,000 patients of the COVID admitted to our hospital, primarily ICU patients. And mortality was almost 53%. And rest, we have tried to follow the 500-600 patients who did not recover at the time of the discharge. And we found about 6% of the 5.6% of the patient had residual damage at the end of the 3 months. We have tried to collect the data telephonically, and those who were able to come to the hospitals, we have tried to call them. So some of these patients had persistent proteinuria and some macroscopic hematuria. So how do you think that persistent macroscopic hematuria and proteinuria, that we should level them now as a chronic kidney disease? We do not understand the basic, what were the native kidney problems at the time of admission. So should we level them as a chronic kidney disease and we should follow like that?
I think the question would become is the duration that you have under observation, if the duration is more than 90 days and there's persistent evidence of hematuria, proteinuria persisting after 90 days, then they meet the criteria of CKD. If it is less than 90 days, then they meet the criteria of AKD till they get to the 90-day time point. So that's no different than anybody else, whether it is COVID or other exposures as such. What's more important is obviously is to seeing is how long do those abnormalities persist and what do you do about them? I mean, if you have continued proteinuria and hematuria, whether or not that would warrant a biopsy at some point would be obviously a broader question to be seen for anybody in that category.
And recently in COVID AKI, we have also tried to see some of the patients of the transplant who came with the AKI, not definitely rejection. We have tried to rule out the rejections on follow-up. We have studied mitochondrial DNA versus NGAL as a predictor of the AKI. And it was looking at the mitochondrial DNA, urinary mitochondrial DNA was looking more sensitive, more specific than your NGAL. So your comment on that, sir? Because you have also stressed upon the mitochondrial stress and dysfunction during this AKI.
Yes, so there are actually ongoing studies in our institution also. So Dr. Mark Kapkowski is a pulmonary critical care physician who has been looking at mitochondrial DNA as a mechanistic pathway for this, both for the combination of our ARDS and kidney involvement. I know from his preliminary studies, he actually showed some of that in abstract form at the ASN, that there is some suggestion that mitochondrial DNA may be better. But recognize that any one of these biomarkers requires a better understanding of what the thresholds are where you say it's abnormal versus normal, and at what phase of the disease you're at. That has been the biggest limitation with these biomarkers, is understanding what is it that's normal and what is it the trajectory at which point you say, I need to do something. That's still something which we don't know.
And that is definitely the problematic question, sir. We have submitted in mitochondria on that. We are just in under review process. Let's see what the results come out, what the comments comes in. Thank you, sir.
I look forward to learning more from you. That'd be great.
Thank you, sir.
Ravi, one more.
Yeah, please go ahead.
One more question. The role of a kidney biopsy, and at what stage would you want in acute kidney injury? I think this has been a topic I know is close to your heart, but what is your current view on acute biopsy in the kidney? Acute kidney.
I think we under biopsy, but I think we are limited to a large extent on who the patient is and where they are and how much risk you're willing to take. I think there are centers where you have the capability of taking that risk and adjusting it. I think in India you do more biopsies than we do in the US anyway. I think I remember we were doing biopsies here all the time, and I think you still do way more. In general, what I've looked at the literature a little bit, and it seems to be obviously related to factors, persistent AKI requiring a biopsy. And persistent AKI, most people are biopsying if they are uncertain, 7 days, 10 days, 14 days out, and then you basically say, well, what's going on? Or if there's persistent aspects. But I would put that question back to you, is what do? You're much more likely to deal with this, and Raja and the whole group here is much more likely to deal with this than I am. What do you do?
Yeah, no, I have been far more in favor of doing biopsies, at least unknown kind of an acute kidney injury, where I can't clinically pinpoint that this is a predisposing factor. So unknown acute kidney injury all of a sudden. It's possible that some of these, when you biopsy them, some of you, as you said, that the previous state of the kidney was not known, and many of them had an underlying chronic kidney disease actually, which manifested like an acute kidney injury in many, and in India it's not difficult that patients come suddenly with symptoms and they say that this wasn't there, but the underlying state of the kidney is not known. There's no test available. You do a biopsy thinking that this is an acute kidney injury, and many of these patients turn out, at least in our state, to be a chronic kidney disease rather than an acute kidney injury. Yes.
Yeah. And I think the other thing that for what has been, at least from the literature and for our own this thing, is that what you think is ATN. I mean, most people just constantly think everything is ATN. It isn't. You may have a infection with GN. You may have other elements. You have interstitial nephritis. A lot of stuff which is coming in. And on the interstitial nephritis side, I think that one of the biomarkers which is appearing to be is urine IL-18.
Yes.
And this is from Chirag Parikh and Dennis Molodina's group, that they have sort of come up with a specific index that can identify urine acute interstitial nephritis as a cause, and obviously identify what exposures would be contributing to it.
I think in the interest of time, we will end this session. Really great discussion. Dr. Mehta, thank you so much for your brilliant presentation. Dr. Ramachandran, Dr. Judd, Dr. Kaul, really thrilled to moderate this session, and hope you'll have a wonderful weekend and a great evening. Thank you all.
Thank you.
Thank you.
Thank you very much. Thank you. Bye-bye.
Thank you, Anupam.
Thank you.
Ravi.